in case of fluoxetine you needs 4 weeks washout period. अगर आपने fluoxetine किसी patient को दी है तो you need a 4 weeks washout period before starting any other serotonergic drug. ठीक है? So it can be asked in the exam कि how you can prevent a serotonin syndrome. So by giving the washout period, normally 2 weeks between two groups of drug, or with in case of fluoxetine it should be 4 weeks. Clear? Now we come to the selective serotonin reuptake inhibitors. These are the drugs: venlafaxine, duloxetine, desvenlafaxine, melanoprazole, and levomelanoprazole. ठीक है? Selective serotonin norepinephrine, selective serotonin norepinephrine reuptake inhibitor. I think you can understand easily the mechanism of action. They inhibit the transporters of both serotonin as well as norepinephrine. Okay? And by this way, they increases the concentration of these drugs in the synaptic cleft and can produces the antidepressant effects. It is more clear in this slide. You have seen here that this is venlafaxine in yellow color, and it will block the norepinephrine as well as serotonin transporters, and by inhibiting these transporters, they increases the level of norepinephrine and serotonin in the synaptic cleft. Okay. These drugs are also administered by the oral route, and it has 50% bioavailability and metabolized by cytochrome P450 enzymes in the liver. It can be used in its clinical uses are slightly different from the SSRIs. Depression is same, generalized anxiety is same. Now these are the different clinical uses of SNRIs, and these differences is because of norepinephrine. These difference is because of norepinephrine, because these drugs inhibit both serotonin as well as norepinephrine. So it can be used in some other disorders as well, like stress urinary incontinence. It can be used in neuropathic pain or sometime in migraine. Neuropathic pain is because of some problem in the neuronal problem. Okay? It can occur with the diabetic neuropathy or with other. Okay, these type of pain is not subside with normal analgesics, with normal non-steroidal anti-inflammatory drugs. जो पेन किलर यूज करते हैं उनसे ये पेन सबसाइड नहीं होती है, एंड इसके लिए हम यूज करते हैं either SNRIs और TCAs, because TCAs का मैकेनिज्म भी यही है कि TCAs also inhibit both serotonin and norepinephrine transporters, दोनों को inhibit करते हैं. So both of these groups can be used in neuropathic pain or fibromyalgia. Fibromyalgia is the musculoskeletal pain, fibromyalgia. And in SNRIs, the preferable drug is melanoprazole. Melanoprazole, although duloxetine is also used in the fibromyalgia, but melanoprazole is a specific drug that is only approved for fibromyalgia. Okay. Then diabetic neuropathy can be used in diabetic neuropathy, and this group is also used some vasomotor symptoms of menopause. Vasomotor symptoms of menopause क्या होता है? After menopause, patient may have a atrophy of the sexual organs, vagina, and may cause dryness, may cause irritability, depression, anxiety. So these are the vasomotor flushing, hot flushes. So these are the symptoms that can be controlled by SNRIs. So this is the quite different clinical uses of SNRIs. Adverse effects, serotonergic adverse effects are same with the SNRIs. These are the some adverse effects that can be caused by norepinephrine, like insomnia, anxiety, agitation, increased blood pressure. Discontinuation syndrome is also occur with SNRIs as well. Okay? Both of these drugs should be tapered off slowly. Difference is venlafaxine. Venlafaxine can cause cardiac toxicity, and can cause arrhythmia. So it can be asked in MCQs. You should you should know about it, that venlafaxine can cause cardiac toxicity. Drug interaction, duloxetine is also inhibit the CYP2D6, okay, and increase the level of TCAs and some other drugs that is metabolized by this enzyme. Same, they causes the serotonin syndrome with monoamine oxidase inhibitors. Okay. Then we come to the tricyclic antidepressant. Tricyclic antidepressants are different in their structure. Some are the tertiary amine, okay, tertiary amine like imipramine, amitriptyline, and doxepin, and some are the secondary amine, that is desipramine and nortriptyline. Secondary amines are formed by the metabolism of tertiary amine. Tertiary amine, amipramine, amitriptyline. Amitriptyline metabolized into desipramine. Amitriptyline is metabolized into nortriptyline. Okay, they have tricyclic ring in their structure. That's why they are called tricyclic antidepressants. Okay, so there is some difference between the tertiary amine and the secondary amine. They have tertiary amine has more anticholinergic adverse effect. The mechanism is slightly different. They causes the reuptake inhibition of norepinephrine and serotonin, as well as it acts as an antagonist on various receptors, on alpha adrenergic receptors, on cholinergic receptors, on histaminic receptors, etc. So it has, that's why it has more wider adverse effect, and it has low therapeutic window. It has low therapeutic window or index. So its toxicity, higher doses may be toxic or may be lethal for the patient. Okay. It inhibits the reuptake as usual with the SNRIs, serotonin and norepinephrine, and it also acts as antagonist at histaminic receptors, H1 receptor, and because of this blockage of this receptor may cause sedation, muscarinic receptor, alpha receptors, and even serotonin receptors. The blockage of the serotonin receptor is beneficial, okay, because it produces the antidepressant effects, but because of the blockage of these receptors, tricyclic antidepressants has more adverse effect as compared to the other antidepressants. You have seen here, I think there is no need to go in detail of the mechanism of action because now it is easily understandable. Clear? But this slide shows the even the blockage of different receptors. If you have seen this table, they block the histaminic receptor, adrenergic receptor, serotonin receptor. You have seen here. Okay, I am not going into detail. The clinical uses of tricyclic antidepressants are they are used in depression. They are used in controlling the bedwetting in children. They all tricyclic antidepressant block the histaminic receptor, so uh, they can cause sedation. They can cause sedation. Okay, sedation. So because of this sedation, this adverse effect, it can be used in depressed patient in having a complaint of sleeplessness or insomnia. Okay, and because of this adverse effect, sedation, it should be given at the bedtime, at the night time, not given in the morning. Okay, and because they block both norepinephrine and serotonin, so it can be used in neuropathic pain. Neuropathic pain. Clomipramine is specifically used in obsessive compulsive disorders. Clomipramine is specifically used in obsessive compulsive disorders, and this group of drug is also used in attention deficit hyperactivity syndrome. Okay? Attention deficit hyperactivity syndrome. I think all of you know about this, in which patient having not concentrating on one thing, okay, hyperactive and not concentrating on one thing. So these are the clinical uses of tricyclic antidepressant. You must remember the name of clomipramine in obsessive compulsive disorders because it can be asked in MCQs that which drug, which tricyclic antidepressant is preferably used for the treatment of obsessive compulsive disorders. Now the adverse effect. It has most commonly, especially the tertiary amine, has more anticholinergic adverse effect as compared to the secondary amine. Okay, and anticholinergic effects, as you know, they are dry mouth, constipation, urinary retention, blurring of vision, aggravation of narrow angle glaucoma, etc. Because of blockage of alpha receptor, they may cause orthostatic hypotension and reflex tachycardia. Okay? Because of H1 blockage, they may cause sedation. Okay. H1 blockage, they may cause sedation, weight gain, and sexual dysfunction because of serotonin, increased concentration of serotonin. Okay. Cardiac arrhythmia because of increased level of norepinephrine. Drug interaction, it has drug interaction of tricyclic antidepressant is very important. It may interact with MAO inhibitors, sympathomimetics, some CNS depressants, inhibitors of CYP2D6, like fluoxetine, paroxetine, and duloxetine, all are the inhibitors of CYP2D6. So it should not be given with this group of drugs. It should be used with caution in cases of angina, glaucoma, epilepsy, and arrhythmia. Okay. Now we come to the 5-HT2 receptor antagonist. 5-HT2 receptor, this receptor is involved with the anxiogenic or depressant effects in the humans. It causes the anxiety and depression, activation of this receptor. So trazodone and nifazodone is a blocker of that receptor, so it can reverse the effect. Okay. These drugs also weakly inhibit the reuptake of serotonin and as well as norepinephrine, and they also have moderately inhibit the alpha-adrenergic and H1 receptors. So because of H1 receptor inhibition, they may cause a sedation. And so because of this sedation, trazodone can be used as a hypnotic, can be used to induce sleep without depression. It is off-label use of trazodone. Okay? It is used for to induce the sleep. These drugs, trazodone and nifazodone, can be used in depression. It can be used in anxiety and even in insomnia. Okay? Or sometimes it is used in combination with some SSRIs or SNRIs to treat insomnia. If the patient having a problem with the insomnia and you have to give the SSRIs and SNRIs, then you may add trazodone to overcome the problem of insomnia. Because if patient having no proper sleep, then the patient may be mentally disturbed. Normally, आम बंदा disturb हो जाता है तो patient will be disturbed. So the adverse effect sedation, GI disturbance, orthostatic hypotension, and you have to remember the adverse effect of nifazodone, that is causes hepatotoxicity specifically. So nifazodone is not very commonly used for depression or anxiety. Trazodone is more commonly used. Nifazodone is also inhibit the cytochrome P450 3A4 and may inhibit the metabolism of triazolim or deltiazine. Now we come to the monoamine oxidase inhibitors. As you all know that monoamine enzyme is involved in the metabolism of norepinephrine, serotonin, and dopamine. And by inhibiting the metabolism, we can increase the concentration of these monoamines in the synaptic cleft. These are the drugs phenelzine and prenylcypramine that irreversibly block the monoamine enzyme. Monoamine enzymes are of two types, monoamine oxidase A and B. Okay, monoamine enzymes are present in the brain, they are present in the nerves, they are present in the gastrointestinal tract, they are present in the liver. And monoamine oxidase enzyme is also involved in the metabolism of tyramine. Tyramine is present in different foods. It is present in different foods. So, by inhibiting the metabolism of tyramine, the release of norepinephrine can be increased. Monoamine oxidase inhibitors are the second line drug, and it is only reserved for the patient who are not giving response to the first line drug, that are SSRIs or SNRIs. Why it is not used? Because of its toxicity and because of its food and drug interaction. Food and drug interaction. As I have told you, it has strong interaction with the other serotonergic drug and may cause serotonin syndrome. Phenelzine and prenylcypramine irreversibly and non-selectively block these both enzymes O and A, while selagelene selectively block in monoamine oxidase B, and specifically it is used in Parkinsonism, but now it is recommended for the treatment of depression as well, selagelene. And the transdermal patch of selagelene is also available to bypass the intestine. Okay, it has. Now we come to the clinical uses. They can be used in refractive depression, not responding to other disorders, anxiety, panic disorders, and Parkinsonism. I'm slightly fast because we have less time to complete this topic and I want to complete it. Orthostatic hypertension, the drug and food interaction of monoamine oxidase is very important. Okay, orthostatic hypertension, weight gain, sexual dysfunction, insomnia, restlessness, confusion, and discontinuation syndrome, like other antidepressants. So all antidepressants should be tapered off slowly. Keep in mind drug interaction. They may interact with the drugs that increases the level of norepinephrine or serotonin, both serotonin or norepinephrine, because it is involved in the metabolism of both. If there is an increased level of norepinephrine, then may be a chances of malignant hypertension. If it is given with the norepinephrine, the noradrenergic drugs, then there is maybe a chances of malignant hypertension that can be uh, life-threatening if it is not properly or urgently treated. So it should not be given with this and tricyclic antidepressant or other sympathomimetic. As you all know that the pseudoephedrine is present is a cold remedy and it is present in some cough syrups. And if you have given the drug monoamine oxidase and patient is already taking this drug, that may cause interaction and may cause malignant hypertension. Okay, so you should be conscious and must take the drug history and advise the patient properly if you prescribe this group of drug. Then food interaction. Uh, it may has a food interaction along with the tyramine containing tyramine. What is the function of tyramine? Tyramine is basically metabolized by monoamine oxidase enzyme, and tyramine increases the release of norepinephrine from the nerve terminal. Tyramine is a substance in the present in the food that increases the release of norepinephrine. So if it is not metabolized by the monoamine oxidase inhibitor, will increase the release. On the end, monoamine oxidase the metabolism of non increase for norepinephrine and can cause malignant hypertension. So now, in which food tyramine is in yogurt, chocolate, red wine, chicken liver, and sausages. So all these things contain tyramine. So if you have prescribed this monoamine oxidase inhibitor, you must tell the patient that patient should avoid all these foods. Then we come to the briefly discussed bupropion, that is tetracycline. Exact mechanism is not known, but bupropion is also increases the level and can be used in depression and seasonal depressive disorders. Seasonal depressive disorders means that disorder occur in the winter, especially in the foreign countries. जहाँ सूरज नहीं निकलता है, patient may have a seasonal depressive disorders in the season, and in these disorders, bupropion is effective. And specific use of and different use of bupropion is the smoking cessation. It can be used in smoking cessation and attention deficit hyperactivity syndrome. Okay. We skip the status fact. Mirtazapine is a tetracyclic and it is an antagonist of alpha-2 receptor. It is an antagonist of alpha-2 receptor and they enhance the release of norepinephrine and serotonin. On the other hand, it also blocks the serotonin receptors, 5-HT2 and 5-HT3 receptors, and even H1 receptor. So it causes sedation. So mirtazapine is also effective in patients having a problem with insomnia, with sleep, okay? Having insomnia. And it is not causing sexual dysfunction. So it can be used in patients having that problem. Or mirtazapine, bupropion, or these drugs can be used as an in combination with other drugs. Now we come to the amoxapine and meprotilene. Amoxapine and meprotilene have a mechanism like tricyclic antidepressant, and the difference of amoxapine is also block or inhibit the D2 receptors. D2 receptor. So it may have some antipsychotic effect. D2 receptor, so it may have some antipsychotic effect, and there is of Parkinson's like adverse effect. They may cause Parkinson's adverse effect. Amoxapine can be used in anxiety, depression, and because of its antipsychotic effect, it can be used in psychosis, or it can be used in combination with other drugs. This is all about antidepressants. Um, no, beta, there is no. This is not an adverse effect. This is not an adverse effect. They may be not be block the transporter in the blood cells. So building is not a adverse effect of SSRIs. Yeah. Okay. This is the end of this lecture, and now we will inshallah with some other topics. If you have any questions, otherwise now it is a time for your next lecture. Allah Hafiz.